side of the world. Welcome to our first SPAEN Knowledge Spot webinar dedicated to the 2021 medical and scientific highlights in GIST. My name is Estelle Lecointe-Arsner. I'm a long-term SPAEN board member and a founder president of the French sarcoma patient organization Sarcoma, and also a former GIST patient myself. It is my honor today to moderate this session and also my privilege to introduce our two medical experts, Dr. Stephen Bialick. I would like to thank you for taking over Dr. Trent, who could not be with us today for professional commitments. Dr. Bialick is a hematology specialist in Miami and has a special focus on circulating tumor DNA, notably in GIST. And Dr. Bialick will speak about two new therapeutic agents which have recently emerged in GIST, which are Avapritinib and Avapritinib. Then we will welcome Dr. Johanna Falkenhorst from Essen, Germany. Dr. Falkenhorst has a clinical focus on GIST and a special interest in the mechanism of resistance and in the development of targeted therapies. Dr. Falkenhorst will speak about novel emerging therapies and approaches in GIST. As it is a webinar, I kindly ask our two guests to do their best and respect the 25 minutes for their presentation so that we can have time to discuss with the audience at the end of the presentation. For the people who are watching us today, you can directly send your questions through the chat, or sending them after the presentation. So, Dr. Bialick, I will leave the word to you.
Excellent. Thank you so much for the introduction, and thank all of you for joining us. This is a great opportunity, and I said before that I apologize, I'm not Dr. Trent, but I hope to fill in big shoes here and give the presentation today. So again, I appreciate the warm welcome. And I'm going to talk today about a few clinical trials recently in the GIST world. And if I could share my screen here, right?
Normally, yes.
Let's see. Did it work?
Yes, yes.
Perfect. You see the whole screen?
Yep. Yes.
Excellent. Okay, perfect. So again, my name is Steve Bialick. I'm one of the second-year fellows in oncology at the University of Miami and the Sylvester Cancer Center here in South Florida. My virtual background, it's usually a real background of palm trees here in South Florida, but it's actually raining today, so I put up this fake office so you guys can see this fake lamp here. But I am going to talk today and what Dr. Trent was going to talk to you all about and give you some clinical updates about a few recent GIST trials and some publications that came out recently over the last couple of years. But just to start with a little bit of background about sarcoma in general, as most of us know, sarcoma is a rare cancer, and it affects less than 1% of adults, more so in children. But because sarcomas come from connective tissue, in our bodies, we have many, many, many different kinds of connective tissue, as you know, fat, nerve, muscle. So the sarcoma subtypes are plentiful. We'll focus today on GIST, but there's always ongoing research that we have in the medical community to more clearly identify the background of these sarcoma subtypes, the genetic landscape, and how these mutations come to be. And this is why we have this research to come up with more effective and potentially less toxic therapies that we can use. So a little bit of background on GIST in general is it's the most common GI sarcoma, GI meaning gastrointestinal tract. And if we look at all the different types of gastrointestinal tumors, GIST makes up less than 1% of all of them. But if we look at the sarcoma world, the GI sarcoma world is 80% GIST. And unfortunately, they do have a high frequency of metastatic disease where the tumor starts in one place and moves somewhere else. And we treat these, and you'll hear this term a lot today, with medications called tyrosine kinase inhibitors, or TKIs. And that's the class of drug that we often use with GIST to treat these tumors. And there's many different gene mutations that kind of drive the background of how these tumors arise in the first place and how they grow. And there's many different ways that we in the medical world can identify these gene mutations of the tumors. whether it's from the tumor itself, we can take a biopsy and look at some sample of tissue, and that's called next generation sequencing, which later in the hour, I think we'll talk more about both the next generation sequencing methods from the tissue itself, the tumor, or from blood, called circulating tumor DNA. And we can identify some of these mutations, both of those ways, to pick up different ways, different methods of treating the GISTs. And the trials that we know of can highlight some of these gene mutations and take advantage of them when we're talking about therapies, whether it's the first therapy that the patients have, or the one after they progress, or the one after that, or the one after that. And so we're always looking for the next line therapy when one treatment either stops working or when the side effects become too strong and we need to change gears. So GIST in general really has no predominance for men versus women. It's pretty much equal. But here in the United States, although it's rare, there's about 4,000 to 6,000 people per year that will be diagnosed with GIST. And so what I want to talk about today, and what Dr. Trent was going to talk to you about, like I said, is the recent clinical trials in GIST. And there's 3 that we'll focus on today. The first one is a trial called the Invictus Trial. And this was published in June of 2020 in the Lancet Oncology, talking about one drug called Ripretinib. And that's one of those TKIs, or tyrosine kinase inhibitors, that I was talking about before. And this particular trial took patients and treated them either with Ripretinib or with a placebo, no drug at all, and then compared the data between the two. And we'll go through the details about this trial when we talk in a few minutes. We'll also go through another trial called the Navigator Trial, and that one was published, several different publications about it, but the one we'll talk about is from Dr. Heinrich's group in July of 2020. And this is using a drug called Avapritinib, or Avakit is another name for it. And then the third study we'll talk about is actually fresh, hot off the press. This publication or presentation was just given at the January last month, the ASCO plenary session, called the INTRIGUE study. Also with Dr. Heinrich's group, and he presented some data talking about the use of Ripretinib and Sutent, or sunitinib, in patients with advanced GIST. So we'll go through the I don't mean to say the gist of these trials, but we'll go through the basic background of each of these studies, starting with the Invictus trial. So in the Invictus trial, like I said, this used a drug called Ripretinib in patients with advanced gastrointestinal stromal tumor, GIST, in what we call a double-blinded, randomized, placebo-controlled phase 3 trial. That is a lot of words, a tongue twister to say, but in essence, it means that there was patients that were either given Ripretinib, the drug, or they were placed in a placebo group. And they were randomized in what we call a 2-to-1 fashion, meaning for every 2 patients getting the Ripretinib, there was 1 patient getting the placebo. And the goal was to have about 80 patients in the Ripretinib group, 40 in the placebo group, and then use the data to compare the two later on. So from February to November, patients were enrolled, and data was collected until the end of May in 2019. Over 12 countries were involved in 29 medical centers. And in order to be eligible for this trial, you had to be 18 years older or older, with a GIST diagnosis, with at least 1 tumor that we can measure, and you had to have had at least imatinib, sunitinib, and regorafenib previously and had progressive disease or intolerance to those 3 medicines. Imatinib is also called Gleevec, just to make that clear. Sunitinib is another name for Sutent, and regorafenib is another name for Stivarga. So those 3 names can be used interchangeably between the 3. And so it started by putting patients into these groups and then tracking them until what we call a blind independent central review took place to look for the scans and see when the patients had progressive disease. And the interesting thing about this trial is can you see my cursor here? My mouse is moving. When the patients were given the placebo drug, if they developed progressive disease, they were able to then switch into the Ripretinib, or the treatment arm of the trial. And that comes into play later on. So I just wanted to show you the demographics. This is a busy slide, but just focus on the left side, we talk about the patients who were enrolled in the trial, and on the right side, it talks about the tumors these patients had. So the median age, or the middle age of the patients that got the drug Ripretinib was about 60, 59 years old, in the placebo group about 65. And the groups were predominantly white men, and they all had at least 3 or 4 prior therapies with the tyrosine kinase inhibitors. Looking over at their tumor characteristics, the most common tumor they had was a tumor of the stomach, a gastric GIST. And on the bottom here, I list the primary mutations. That's what I was talking about in the beginning, where we can check the tumors for different types of mutations, exon 9, exon 11, a whole alphabet soup of letters and numbers. But really what I want to point out here is that the majority of the patients in this trial had this exon 11 KIT mutation, about 55% in the ripretinib group and 64% in the placebo group. So this graph, and we'll see graphs like this often, I should point out a disclaimer that I'm colorblind, and it's a challenge in my world, especially when I'm presenting data that has colorful charts. So I'm gonna say dark and light. I hope that rings true, that this line on the right is darker than this line on the left. Maybe this is a blue or purple and this is a gray. It could be completely wrong. I actually don't know. But the line on the right, the dark one, is the patients that had the drug ripretinib. And the line on the left is those that got the placebo. This dotted line here in the middle is the 50% mark, or the median line. So I know it's a little confusing, but what this is pointing out, what you can see, is that the patients that had the ripretinib had a longer time of what we call median progression-free survival, a longer amount of time that they had the GIST, but it wasn't getting worse. So if we take this median line, the 50%, and we have this arrow here, which is about 6.3 months, compared to this 50% line of about 1 month in the placebo group. So what I'm trying to show here is that the patients that had ripretinib definitely had longer time without progression compared to those that got the placebo. Here, we're looking at something called the overall response rate, or ORR. And so, again, another busy table, but what I want to focus on is in the ripretinib group here on the left, you can see that there is about, at 6 weeks, 12 weeks, you have about 56% of the patients that had stable disease, their tumors didn't grow, and about 12 weeks, 40%, they had stable disease, their tumors didn't get worse. Compared to the placebo, where the number is drastically smaller. You can see 9 patients here and 2 patients here who had stable disease compared to the higher number here. And the people that progressed were mostly the placebo group, 28 patients of the 44 compared to 16 of the 85. And in the ripretinib group, there were 8 patients that had what we call an objective response, meaning that there was some activity of the drug affecting the tumor in a positive way. This graph shows us something else that we look at called TTR, the time to response, versus DOR, the solid line here, duration of response. So of those 8 patients on this slide, these guys right here, those 8 patients, let's just call them patient A, B, C, D, however we want to call them. And this patient A, the top line, just shows that about 3 months into him getting the ripretinib is when he finally started to show some response. And then that response lasted from 3 until 7 months at the time that we stopped collecting the data. So at the end of the data cutoff period, which for this trial was the end of May in 2019, 1 of these 8 developed progressive disease, but the other 7 were still responding nicely or still having a disease response. Here, compared to the chart before where we just looked at progression-free survival, that means that the patients were still alive, but hadn't had worsening of their disease. Now in this chart, we're looking at what we call overall survival. And the patients in the ripretinib group, again, the darker line, it's clear that they had longer time living compared to the placebo group who had a shorter time living without the drug. And so what we're trying to hone in here, basically in summary, is that the overall survival, whoops, back on this slide, was higher for the ripretinib group. But we have to keep in mind that one of the caveats here is that the patients, like I told you, the placebo patients were allowed to switch in or cross over. So the overall survival is kind of hard to analyze in trials like this where the crossover happens. The ripretinib drug, this is a list of toxicities. Now, you'll see a whole abundance of side effects, or toxicities as we call them, when we talk about drugs. But anybody that takes Advil or Tylenol, if any patient ever took Tylenol and sneezed, legally that has to be reported as a side effect, essentially. And so oftentimes we list everything that happens to patients, but we grade it in a scale of 1 to 5. 1 to 2 is a minor reaction, not reaction, but an adverse effect or a side effect. and grade 3, 4, and 5 are more severe. So we focus on those, but what's important to know about the ripretinib drug is that there was very little grade 3, 4, or 5 side effects. The most common, the grade 1s and 2s, or the more minor toxicities, were what we call alopecia or hair loss in about 50% of the patients. Of that 50%, 24 of them were women. Also myalgias, which is some joint pains and aches, nausea and fatigue. Those are the top 4 most common. And like I said, the more severe reactions, the 3, 4, and 5, those toxicities were rather low. You can see the number of patients here that it happened to, only 1 to 4 here for one of these blood enzymes that was elevated. This just lists a little bit more of the toxicities and what can happen. But again, very small numbers. So all in all, the Invictus trial, that first one, basically shows that this drug, ripretinib, as a 4th line or more therapy for the advanced GIST patients, really improved outcomes in both the progression-free survival, the overall response rate, and the median overall survival. But again, I'm just highlighting the underestimation of the overall survival here because of that crossover. But there were some pretty durable responses with the ripretinib, and that was the takeaway from this trial. Going into the next one, the Navigator trial, this is where they used a drug called Avapritinib, another novel or more new agent I wanted to talk to you guys about. And it was used in patients with PDGFRA D842V. Again, so many letters, so many numbers, but what it means is that those letters are a mutation in certain GISTs that we can target or try to target to see if certain drugs will be more effective in patients that have that particular mutation than those that don't. And that's sort of what was going on here. So in this trial, there was 46 patients with GIST. 23 of them had one of the mutations called KIT. The other 23 had a mutation in this gene, PDGFR. But anybody that had advanced GIST, or at least 2 prior tyrosine kinase inhibitors, or one of these mutations, didn't matter, qualified for this trial. They were given the drug, avapritinib or Avakit, for what we call the RP2D, the recommended phase 2 dose. And then we studied things like the overall response rate, the duration of the DOR, the duration of response, and then the safety of the drug in 2 different groups. One was any patient that had 4th line therapy and GIST. It didn't matter whether they had the KIT or the PGFR. And the other group was only patients that had this mutation in PDGFRA or a mutation in this exon. So again, demographics of the patients. Again, you can see that it was predominantly patients that were white males. But in this group, the PDGFR exon 18, you can see that none of those patients had that KIT mutation because they focused on this particular exon 18 mutation. Whereas in the other group, the 121, N equals 121 means that there were 121 patients that we were looking at these patients as a 4th line therapy for their GIST. So these plots, these graphs are called waterfall plots. And basically, as if water was falling down, the 0 line here, let's say that's we'll call that the start time of starting the drug. Each of these, again, blue or purple, I don't know, these lines are 1 patient. So on the left, if this number goes up, that means that the tumor is actually increasing in size. And in our world, we don't call it progressive disease unless it's 20% or higher than its initial size. And we don't call it a response unless it's 30% or smaller than it initially started. I don't know if that's clear, but so these 2 patients, their tumor got bigger, but the rest of these guys, all their tumors got smaller. And when it meets this line all the way down here, negative 100, that means that that was a complete response. So what we can see here is that there were lots of patients with this exon 18, 95% that had a tumor reduction. The size of their tumor got smaller. And partial response was about 34 patients in this trial, where the complete response, the CR, all the way down to the 100 was these 3 guys at the end. Then we look at the duration of the response. And what I'm trying to highlight here is, again, this number goes down, but if we look at the 50% line, the median line, the patients in this group with this exon 18 PDGFR mutation that were getting the Avakit, they had a duration of response that at the time we stopped collecting data, 78% of the patients were still responding, 28 out of the 36 in this group. So they still had some response here. Another way to look at this is that after 18 months, which is this x-axis here, this is months, 50% of the patients were still responding, or more than that, actually. And then we look at this other group. This is the patients, the 100 and something patients that got the AVA kit that didn't necessarily have that exon 18 mutation, but they were being treated because they had advanced disease and had already had 3 or 4 lines of therapy before. And you can see again that there's some anti-tumor activity in all these patients getting the avapritinib. Their tumors shrunk. In this one, all the way at the end, it's shrunk completely, the complete response. That's what CR stands for. PR is a partial response, SD is stable disease, and PD are these guys with progressive disease. The disease got worse. So same graphic, but for the other group now. Again, showing that there was some duration of a response, a median of about 10.2 months for the people that responded to this drug before switching or progressing. And here's some of the side effects with the avapritinib. Again, nausea, fatigue are the most common. And most of them were, again, the lower grade 1 or 2, not the severe grade 3 or 4s. And in fact, no patients had a grade 5 reaction here. And most of the patients were able to stay on the treatment through the whole trial. Less than 10% needed to be discontinued for some treatment-related adverse effect, TRAE. And that's what we're highlighting here. And so in summary, the Navigator trial, the avapritinib trial, basically demonstrated that there is clinical activity and favorable tolerability in the patients that have that exon 18 mutation, but also in patients that are just needing the next line therapy after progressing or having intolerance to the TKIs before. And so avapritinib here showed that the response rates are higher than reported with the other TKIs, and there was some duration of response. And down here, we talk about the safety profile. It's manageable, it's predictable, we know what the side effects are, and we can counsel patients on them and monitor for those symptoms, but there were no grade 5 treatment-related adverse effects in the Navigator trial. And then the last one I wanted to touch base on, again, this one's brief because this data is still up and coming, and this was presented at the ASCO plenary session last month, the INTRIGUE study. And this one is a randomization of 1-to-1, whereas in the Invictus trial I talked about before, there were 2 patients getting ripretinib for every 1 getting the placebo. In this INTRIGUE trial, which was a randomized open label study, looking at the effectiveness or the efficacy and the safety of 2 different drugs, ripretinib or Qinlock versus sunitinib or Sutent. And this is in patients, again, with advanced GIST, previously had Gleevec or imatinib. And so they took patients and randomized them. You either got the ripretinib drug, 150 milligrams a day, or you got the Sutent drug, 50 milligrams a day. Although this was 4 weeks in a row that you got treated and 2 weeks that you were off treatment. Whereas the ripretinib group, they got the drug every single day, continuously. And then they looked at things like we already talked about before, the PFS, or the progression-free survival, based on patients that had this exon 11 mutation, and then the group of everybody else, all the patients in general. And so what we see is this ripretinib arm, the patients that got Qinlock, and this is the patients that got Sutent, N equals 227 patients that got Sutent, 226 that got ripretinib. And of these 2 groups down here, I've written that 163 patients in the ripretinib arm had that KIT exon 11 mutation. 164 in the Sutent arm had that KIT exon 11 mutation. And so the demographics between the 2 groups were pretty balanced. And what we looked at, or what they're looking at now, is the overall response rate. And you can see that the response rate in the ripretinib group is a bit higher. This is the percentage. 24% of the patients with ripretinib or Qinlock had a response if they had this exon 11 mutation, compared to about 14 or 15% with the Sutent. And on this side, we're looking at all the patients, AP, all patient, intention to treat, ITT population. And so looking at the plots, like we looked at last time, where we look at median, the 50% line, and the progression-free survival, the time that the patients are living but haven't progressed, you can see that they're relatively even in the all-patient trial, and maybe slightly better. The median progression-free survival in the ripretinib group is about 8.3 months here, compared to 7 months with the Sutent. But overall, this study is showing that it's not necessarily true that the QINLOCK or the ripretinib is superior to the Sutent or the sunitinib in terms of progression-free survival. But it may be observed that the ripretinib has a higher progression-free survival in the patients with this particular mutation, the exon 11. And this is just further highlighting that PFS chart from just before. And here's looking at some of the side effects of these two drugs, the most common being the hypertension or high blood pressure with Sutent, grade 3 and 4. You'll see the grade 4 reactions with the Sutent. This is neutropenia or a neutrophil count, which is a subset of white blood cells that gets really low with Sutent in this small percentage of patients. But the side effects are interesting to look at in terms of the tolerability of Sutent compared to the ripretinib, where you can see more hypertension from, in the Sutent patients than the QINLOCK or the ripretinib patients. And so the INTRIGUE study, basically in summary, showed us that the ripretinib over sunitinib is not necessarily much better in terms of median progression-free survival. We saw that the Sutent had a longer median progression-free survival than expected, and that the ripretinib had nearly double, not necessarily, about 24% of the patients had a response compared to the 14 or 15% with the Sutent. But we showed the side effects, and it looks like the ripretinib was better tolerated, less of those grade 3 or 4 toxicities. But overall, it's relatively safe and effective, and it's important in patients that have progressed or have become intolerant to the imatinib. And so putting it all together to talk about all three in one, this is just my meat and potatoes slide, just to talk about, in summary, the three trials we discussed today are showing us that the primary and what we call resistance mutations in GIST patients should really be evaluated by the doctors and looked at, because the treatment options we have can differ based on your particular mutations. And I think it's great that the talk after us is gonna hone in on some of the ways we can identify these mutations. But the two drugs we wanted to mention, or Dr. Trent wanted to parlay to you guys, were the avapritinib and the ripretinib. And the avapritinib is the one that is showing some activity in this PDGFR mutation GIST patients, but it does show activity in all patients with GIST as well. But the ripretinib also shows some safe and effective use in the higher line settings. And so at the back end of this, I think we'll have time for some questions. But again, this is our team here at the University of Miami down in Florida. It's a big team, and I think sarcoma teams in general, the bigger the better. And I just wanted to thank you guys one more time for allowing me to step in last minute. I know this was unexpected, and I, for the third time, apologize that I'm not Dr. T. But I hope this was informative for you guys, and I look forward to the questions at the end. Thank you guys again for the time. Oh, Estelle, I think
you're still on mute.
I was making a compliment and you didn't hear me. So I was just saying that your presentation was as good as the one of Dr. Trent. So thank you for sharing this very precious information about us. I personally have a lot of questions to ask you, but I will keep them for the end of the presentation. So unless some people have very burning questions now, maybe we should directly move to the presentation of Dr. Falkenhorst. Is she there?
Yes, I'm here.
Oh,
I'll share my screen now. Just a moment. Oh, sorry. Can you see everything? Yes. So thank you very much for the opportunity to talk to you today about the novel emerging therapies and approaches in GIST, which will focus on two very interesting clinical trials and a method to analyze patient tumor blood. And after this very good introduction into GIST in general, I will directly start with one of the big questions we have. So why do GIST become resistant? And what you see here is a patient with an extensive liver metastasis You see on the left-hand side these dark masses. And when we now start treating patients with imatinib, you see that these masses get smaller and get darker, which means that the tumor liquefies. But the problem is when we treat our patients for a longer time, in this case it was 18 months, you will see that there are some small nodules growing again in this mass. So the tumor comes resistant. And when we now change the treatment to sunitinib in this case, or Sutent, you will see that there is one nodule that is growing any longer, and then that there's one nodule that is shrinking. And this points out to the big problem we have in GIST. So when you take a biopsy from this like liquid mass, you will always find viable tumor cells inside when you look under the microscope. And when you then take out this growing nodules and search for resistance mutations, you will always find a bunch of mutations. So the tumors are not the same genetically, but they are very heterogeneous. And then brings us to the problem that you see here. So imatinib is working very good for 1.5 years in median, but when we change the treatment to other TKIs, you see that they are working not this long. So sunitinib, regorafenib, and ripretinib work around half a year in median. And the problem is, what we think is that we have accumulation of resistance mutations, so different resistance mutations, and that the tumor gets more and more heterogeneous. So all of the trials I would talk to you today about is about handling resistance. So we have the aim to improve treatment, and there's one interesting trial with the KIT-dependent or KIT inhibitory treatment combination, and one trial that doesn't use KIT inhibitors, but immunotherapy in GIST. And we will talk about the improvement of detection of resistance mutations by using liquid biopsies, which means analyzing circulating tumor DNA. So we'll start with the TKI combination. So what you see here is an overview of resistance mutations. So we have areas in the genome where mutations lead to less sensitivity to the KIT inhibitors we know. So in these areas, you see how good the drugs work. So imatinib do not work in these resistance mutations. This is why we call them resistance mutations. But if you look at sunitinib, you see that exon 13 and 14 mutations are sensitive, but the other ones are resistant. And when you look at the other drugs, you will see that there's no drug that covers all resistance mutations. So the trial evaluated one new drug called PLX 9486, which was working on exon 17 and 18 mutations. And the first trial showed that this drug was very well tolerable. So, oh, I'm sorry, there's a mistake in the presentation. So you see that the sunitinib is sensitive in the exon 13, 14 mutations, and the PLX is sensitive for the exon 17, 18 mutations. So they evaluated the combination of both. So you may ask yourself, why don't we combine the TKIs we know from the past? And what you see here is a small overview of side effects we know for these drugs. And what you see is that they all have another spectrum of adverse events, but these spectra will overlap. And what we know from the past is when we combine these any longer, so combination was not possible until now. So in this trial, patients were included that had relapsed or refractory GIST, so imatinib was not working any longer, and they must have had imatinib pre-treatment. There were 18 patients included, and 12 of them had 3 or more prior treatment lines. And what's interesting is that 13 of 18 patients had sunitinib treatment before. So the combination of both drugs was tested, and first of all, there was a very low dose used for both drugs to see if it's tolerable, and during the trial, the dose was increased for both drugs. And these were the results for the progression-free survival. So the time the drug was working in patients. And the interesting curves are the black one in the middle that had the higher dose of PLX with a median progression-free survival of 5.8 months, comparable to sunitinib or regorafenib. And in violet, you'd see the curve for the combination, and the median progression-free survival estimated was 12 months, so 1 year, which is very good in this last line. And here you see a so-called swimmer plot, which shows the duration of response, and the 7 patients highlighted on top had a response for more than 1 year. And when it comes to tolerability, which is one of the main questions of this trial, you will see these side effects, any grade and grade more than 3. That's what Dr. Bialick explained to you a few minutes before. And what you see here is that the main side effects, severe side effects, were diarrhea, anemia, fatigue, and hypertension. So what we know from Sutent alone as well. But there were no additional side effects observed. So to take home from this study is that this combination seems to cover relevant resistance mutations, and the combination was tolerable with grade 3 anemia, fatigue, and diarrhea. And the progression-free survival was 12 months for the combination. But we always have to take in account that there's just a low number of patients analyzed, so 18 patients, but there is a phase 3 study ongoing in the US, as far as I know. Okay, so we'll now talk about the next clinical trial that covers immunotherapy in GIST. So immunotherapy is a very popular treatment in different carcinomas, but is also tested in sarcoma. So there's the burning question of many of our patients we see in our clinic, why can't I have immunotherapy? So you might have never heard about immunotherapy in GIST before, but what we know is that GIST tumors do not only consist of tumor cells, but we also have immune cells inside our tumor. And what you see on the left-hand side is a brown staining for any immune cells. And on the right-hand side, you see staining for killing immune cells. And you see brown dots in every tumor, which were more in the PDGF receptor alpha mutant GIST, but we have tumors where we might target these immune cells. So if we have these immune cells inside our tumors, why don't they kill the tumor? I think that's an important question. And I will now try to quickly introduce you into the basics of immune checkpoints. And what you see here on the left-hand side is that we have cells that show antigens on their surface. So they show parts of the cells that might be damaged by tumor growth or by bacteria or virus. And these damaged proteins might be recognized by T cells, which are immune cells. And these T cells get activated and then are able to recognize cancer cells or infected cells and kill them. But the problem is that we normally have situations where the immune system overreacts, so might act against normal cells. And to inhibit this overactivation, you will always have not just the one interaction between immune cells and other cells, but you will have regulatory interactions like activation signals, but also inhibitory signals, which you see on the down part. There's one important one, the B7-CTLA4 interaction, which can be inhibited by ipilimumab, so the immune reaction can occur. And regarding the interaction between T cells and cancer cells, we have the same mechanism. And there, maybe you might know the PD-1, PD-L1 interaction, because medications targeting this are very common in the use of other tumors like nivolumab and pembrolizumab. So there are clinical trials in GIST using immunotherapy. Here's one combining dasatinib and ipilimumab. Dasatinib is a KIT inhibitor as well. We had a median progression-free survival of 2.8 months in the third line, which is half of regorafenib, just to say, and when you compare this to the dasatinib alone clinical trial in second line, PFS is the same. So there might be no profit from immunotherapy. And another trial evaluating pembrolizumab, the PD-1 inhibitor, combined with cyclophosphamide and sarcoma. You see the GIST patients marked here with the GIST symbol on a waterfall plot. You see that most bars point to the top, which means that the tumor was still growing. So the questions this trial, this actual trial would like to answer was, what if TKIs do increase response to immunotherapy? So the combination is not working. And what if heavily pretreated patients do not rely on the KIT signaling so much or any longer? So maybe the addition of KIT inhibitor will not make patients profit from this therapy. So they took 36 patients, of which 32 had 2 or more treatment lines. Patients were in a good shape, clinical shape, and 32 of them were KIT mutant. And 19 patients were treated with nivolumab alone, which is a PD-L1 inhibitor, and 16 patients were treated with a combination of nivolumab and ipilimumab. And what you see here is a swimmer plot again. So the longer the bar, the better, or the longer the response. And this is the one for nivolumab. And I just highlighted the 4 weeks progression-free survival for placebo, as you saw from the Invictus trial, just to compare. And when you see now the combinational therapy, there are a few patients responding very long, but there are a lot of patients who had not markedly longer response than placebo alone. And on the Kaplan-Meier curve, you see here, you see that many patients do progress very, very fast. And I just put the Invictus trial curve next to it, so you might see the that the curves for placebo and looks very similar at the beginning of treatment. But we have some patients that profit for a long time. So compared to placebo, we have an improved PFS. That's what the authors conclude in this trial. And some late-line patients do profit. But what we don't know yet is which patients do profit. And if we had any prognostic markers that profit. What we don't know is the efficacy compared to a tyrosine kinase inhibitors or KIT inhibitory re-challenge. And we still don't know if we should add a TKI to immunotherapy to improve the response. And another thing is in which treatment line would the immunotherapy works best. So we don't know at which time point the tumor is best infiltrated by immune cells. Okay, coming from treatment to diagnostics. So we'd like to improve the detection of our resistance mutations. And what do we do to monitor disease and disease status and resistance? We have to talk to our patients and to do physical examination. And what we always do is CT or MRI scan to see if the lesions are growing or shrinking. But we always have to take into account the radiation exposure and also the difficulties in diagnosing a response in GIST. If we have a lesion that is growing and if we are uncertain, we will take a tumor biopsy for mutational analysis. But you know that if we take one biopsy, we will never cover the heterogeneity of this tumor. So a possible answer to this problem would be the use of liquid biopsies. So to analyze tumor mutations in the blood, but what we don't know yet is the clinical relevance and the reliability of this method. So why can we find tumor DNA in the blood of patients? So on the down part in this red box, you see a tumor, and tumor cells are dying. That's normal during course of disease, during treatment. And when cells die, the DNA will shed into the blood. And when we then go and take a blood sample of the patient, we might find free circulating DNA from the tumor, but we will find also DNA from normal tissue cells. Okay, so to draw blood is quite easy. So why don't we use the ctDNA analysis in the clinical routine yet? The problem is we don't know which patients will profit. So the disease burden might be a hint to if it works or not. So we have the patient and then we have to take the blood. There are different methods to take the blood. We can take the routine vials, or we can take specialized tubes where DNA is stabilized, which are very, very expensive. We then have to process the sample. We need someone who takes the sample, who does the centrifugation, who does the freezing, or just put it in a box and send it away for analysis. And then if we process the sample by ourselves, we need to know which method we use. There are automated methods, but there's also a way to do this manually. We don't know which works best right now. And then we have to decide how to analyze the DNA we got. So there are different methods like PCR, targeted sequencing, or whole genome sequencing, which I will introduce shortly. So the questions we have here is who collects the sample, who prepares it, who runs the analysis, who does the clinical interpretation, which is not this easy, which patients will benefit, and who pays for it, because this is not cheap, actually. And in Germany, and I think in Europe as well, there's no coverage of this methodology for GIST patients. So which method might be most useful in GIST? The first thing is the digital PCR, where we can detect single known mutations. In GIST, we really pretty know quite well about the resistance mutations. So this method would work to follow up for specific mutations. I'm really sorry for the background noise. The next method is targeted sequencing, or also called panel sequencing, where we have predefined gene regions that are covered. So all mutations in this region will be found. And it's really good to have a resistance overview with this method. And there is the option to just sequence the total genome. So we have all genes covered, but this is only for research purposes right now. So from left to right, we have more mutations covered, but the more mutations we cover, the less sensitivity and specificity we have. So we have more problems with detecting mutations that are there, and we have more problems with sequencing errors. So we see results that are not true. And the methods get more expensive and more expensive to the right. So the method that's used mostly in clinical trials or in GIST patients is the targeted sequencing approach. And there are many companies who run these analyses, but they cost around like €1,000 or more. So which patients would benefit? What you see here on the top is the amount of tumor DNA in the blood with this red bars. So patients in early stage of disease, localized disease or resected GIST shed very, very low ctDNA in the blood, yeah, it makes sense, I think. So this is very hard to detect whether patients with advanced metastatic disease might have higher loads of tumor DNA in the blood. And these are the methods we have. So both on the top are panel sequencing methods, and on the down part, it's PCR or digital PCR, which is way more sensitive. And the panel sequencing might might find mutations in these patients that are advanced and metastatic. Okay, so why is it of interest? As you already know this, this table here, if we knew the resistance mutations in our patients, we might use a TKI that targets the mutations that we found in patients' blood. So this is one example of a patient that got liquid biopsy, and in this biopsy, there was a resistance mutation found, this exon 17 mutations you see on the top and on the bottom, and then the patient was placed on ponatinib because this medication works good in this mutation, and you see that the patient responded very well with this very huge liver metastasis, and it was shrinking and still getting smaller after 12 months of treatment. So ctDNA analysis may guide therapeutic decisions in GIST and may display the tumor heterogeneity, but the analysis is error prone and needs to be conducted by experts or companies that are specialized. Standardized protocols are missing yet in the regarding analysis at university hospitals or sarcoma centers, and we really need prospective clinical trials for further validation. So thank you very much for your attention. I hope that you could understand me, even if there was noise in the background, and I'm now open for questions.
Thank you very much, Dr. Falkenhorst, and thank you also to be so sharp in time. Maybe now we can move to the questions. Do we have questions from the audience? Okay, so I will start with my questions for Dr. Bialick, and I would like to ask a question about the Invictus trial. Was dose escalation possible in this trial?
In the Invictus trial, where we're talking, the one where we talk about ripretinib versus placebo, the patients that they used initially had a dose of 150 milligrams, and the patients that had the placebo did not. And they pretty much continued on the same dose, but once there was disease progression, there was a phase where they were escalated to twice a day dosing of the ripretinib versus the once a day dose. The data that I was showing you, all those tables, were the time from the initial randomization, but I'm not necessarily sure what information I have on the patients specifically that were dose escalated, but there was a group of patients that did get, after they progressed on the 150 milligram dose, they went up to taking that same pill twice a day.
Okay, and do the toxicity data of these patients were included in your table or not?
Yeah, the toxicity, the data that we had was included for all the patients that were in the initial group, the 85 patients that were taking the ripretinib from the beginning. And so I'm not sure if the twice a day dose was included in those toxicities that I was talking about. But that's a good question. I'll look into that, but that is a good question.
Okay,
to know
it was just to know. Okay, it was just to know if there was a significant impact on toxicity.
Of course, a higher toxicity with taking the dose twice a day is definitely an interesting question, and I wish I had the answer for you, but I don't.
Okay, we have a question from the chat. Does ripretinib have a different mechanization than Sutent?
They both work as they're both tyrosine kinase inhibitors, and in terms of where they actually work on what part of the exon or the loop that they're affecting, I think there is a minor difference in them. Oh, there was another question. I'm not Dr. Falkenhorst. Do you know the specific mechanism of each one?
Yeah, I can try to explain because it's quite interesting for the ripretinib. So Sutent rather works like, than in imatinib. It binds a little different, so it covers resistance mutations. But the ripretinib is a so-called switch inhibitor, switch pocket inhibitor. So it works on a different part of the kinase. So KIT has like a tertiary 3D structure where it has like an arm that swings out at the time of activation. And the switch pocket inhibitor binds in a way that this arm cannot switch out. So the kinase is not able to get activated any longer. And that's the mechanism. And the company says that this new form of binding to the kinase makes this medication work in all resistance mutations, which is not this true as we know from the clinical trials, but that's the mechanism of action. I hope it was understandable.
It was. So we learned from this drug that it improved PFS, it improved the stability of the disease, and it had limited toxicities. So could we consider that these data are strong enough to consider ripretinib as a future standard for fourth-line treatment in GIST?
Yeah, I mean, I think right now from the data that we have, once we're getting into third and fourth line therapies and we're looking for what to use next, I think that this data right now would support the use of ripretinib as a next line, especially once we move up to the fourth or fifth. But as far as standard of care goes, or what we would recommend, based on guidelines, I think all of these trials still have ongoing data that we're pulling from. But I do think the future is near, and that this ripretinib drug may become what you're saying.
Okay.
I might add that ripretinib is approved, EMA approved since, I don't know, 1 month. So we can get it in Europe, and I think we can get it in the US as well,
Yes.
as far as I know. Yeah.
Okay.
But just in fourth line, so not in the second line.
Yeah, of course. Okay, and I would now ask a question about the Navigator trial. Is there a chance that this drug could be also tested in the pediatric patients?
That is a good question. I feel like all the questions I'm telling you are great questions, and I don't have the best answer for you. But I don't know about the PD. We use all these trials that I mentioned are the eligibility requires you to be 18 or over. I'm not necessarily sure about the pediatric population, but I don't know the answer to that.
Okay.
So KIT and PDGF receptor alpha mutations are very, very rare in children. So there might be single cases, but normally these patients don't carry mutations except in hereditary GIST. So if the parents or someone else in the family has the same disease.
Yeah, maybe my question was not accurate enough. I just meant, could it be tested in mutations that were very rare and that actually did not get any therapeutic options for the moment, efficient therapeutic options? Okay.
So I might try to answer. So we had in Germany, we had an extended access program for ripretinib, which we don't have yet because the medication is approved. But if we have a sensitive mutation, you can always try to get an reimbursement from your insurance companies. But you have to ask for that with the data we have in the background for several mutations right now.
Okay. Then I had another question about the INTRIGUE study. You show a table where there were lower response rate in sunitinib. And do you think it could be influenced by the 2 weeks break compared to the continuous therapy under ripretinib?
It could be, but in the INTRIGUE trial where they were looking specifically at the two different populations, one with the patients that had the KIT exon 11 mutation, and the other was all patients in general. The dosing of the ripretinib was a daily dose continuously, but the Sutent dosing, the 4 weeks on, 2 weeks off, was what was tested. And I'm not necessarily sure if it was more so because of the exon mutation, why the ripretinib appeared to have a higher overall response compared to the Sutent. So I'm not sure if the dosing or the break had anything to do with it.
Okay. I also had a question regarding the use of immunotherapy in GIST therapeutic approach, because it's been quite disappointing for the moment. So is there really an interest for the moment to go further in this therapeutic approach, given the very poor results coming from this?
I mean, what we see on a regular basis in GIST trials is that there are some patients that seem to profit for quite a long time, and there were patients profiting for more than a year, which is totally astonishing in this late line setting. What we don't know if these patients would also profit just from placebo in this case. Maybe they just have an course of disease where the tumor is not progressing fast. We don't know yet, but there might be some patients profiting, and we need these biomarkers. We know that from other tumors where we use immunotherapy, that we need something to test before to see if this immunotherapy works, but we don't have the markers yet.
So
it's difficult to say.
I just want to be sure that you said that we couldn't define yet the population that could benefit from it. Is that right?
Yeah, I think when I got that correctly from the publication is that they are still analyzing the cohort for biomarkers to see which patients might profit.
Okay. Is there any other question from the audience? Don't be shy.
So we have a number of questions.
Oh yeah, there was a question here in the chat about the liquid biopsies, asking about the clinical trials and why they're not started. And I don't know, Dr. Falkenhorst, you have that answer. I think there are clinical trials now, not necessarily with full data sets yet, but I think those are in the process.
Yes, that's right. So there's not a clinical trial comparing liquid biopsy to CT scans or something. So just to see whether patients profit, but nearly all clinical trials, also those trials that were reported here, take blood and analyze blood. So they do liquid biopsies and do these analyses. And I haven't shown the slide because of time reasons, but also in the trials we have heard about today. So for example, in the PDGF receptor alpha cohort for Avapritinib, you see that these patients that have a high amount of ctDNA in their blood respond less, they respond worse to Avapritinib than those who have not this big concentration. And if we analyze the blood for mutations of exon 9 or exon 11, so primary mutations in the blood for patients treated with ripretinib, we also see that the detection shows us that the exon 9 patients do profit less. So there is a lot of research ongoing right now. That's right. So there are clinical trials, but we still need the results.
We have another question. I have heard about of a drug called Immunotherapy, HSP90 inhibitor. Do you have any research on that? And she said that she believes the trial was in Japan. Have you heard about it?
So I've heard about the inhibitor because it was evaluated like a lot of years ago in vitro. So we think that this is a promising drug group for GIST patients. There's one publication that evaluated the resistant patients following Avapritinib treatment that showed that these patients might respond to HSP90 inhibitors. But I don't know about any GIST patient including these trials. And what I heard about these medications were that they are not well tolerated. But I don't know about the actual results of clinical trials in other tumors. So maybe Dr. Bialick knows more than I do.
I think I know that of the similar situation that these heat shock proteins they're looking into, but the full, I know that that paper that was published, the Japan trial that I think they're referring to, I'm not sure about the tolerability. And I think in that trial, they were looking particularly at progression-free survival and overall survival, and it was a little bit longer. but I think the full data set in terms of the heat shock protein inhibitors in general is they're still looking into.
Okay, thank you. There is someone asking for more explanation about the substance of Bialick 9486.
So it's a classic, tyrosine kinase inhibitor, which binds to the activated kinase. So imatinib is not able to bind the activated KIT. It just binds the inactivated KIT, and so KIT cannot be activated any longer. But the problem is in tumors that this kinase it's nearly always activated, and Bialick is able to bind this activated kinase and to inhibit the signal, the pro-survival signal. That's the mechanism.
Okay. Is there any other question? No? I think we finished with the questions. Okay, so we clearly understand through your both presentations that mutational status is key in the management of GIST tumors to determine the best therapeutic approach. And I would like to warmly thank you to take the time for sharing these very precious information. Therapies in resistant tumors still remain a big concern for the GIST patient community, especially in patients harboring very rare mutations or having failed to several therapeutic lines. So it is important to understand that there is still new therapies coming in this population. It's a great source of hope for this population of patients. So thank you very much for your presentations. And I would also like to thank the audience for attending our webinar tonight. I think that the next one will be next Wednesday. Am I right?
Exactly. It's going to be on desmoid tumors.
Okay. Maybe you want to add details about the time. And
it's actually the same time as today. So it's next Wednesday, February 16th at 5:30 CET. So you're all welcome to join us again. And 2 more Knowledge Spot webinars are waiting. We're going to have one on bone sarcomas. That's going to be March 9th. And the last one on soft tissue sarcomas is going to be March 23rd. And you can all check the dates on our website, which Michi has kindly already posted in the chat.
Okay, thank you very much. So thank you, everyone, and see you next time for a nice webinar. Good evening.
Have a good night,
good morning for the others. Thank you, Dr. Bialick. Thank you, Dr. Falkenhorst.
Bye-bye.
Thank you very much.
Bye-bye.
Great presentations.